Hello, sorry, there's a bit of confusion in the start here, but my name's Clare Delany and I'm chair of the Victorian COVID Cancer Network Expert Ethics Group. I'm your MC for today, and I'm also going to present to start the presentation and introduce the panelists and then sum up at the end. So I just want to know, should I be sharing my screen now? I'm sorry about this.
Hi Claire, it's Cynthia here. You share your screen when you start to set the scene. So if you just want to do the housekeeping.
Oh, okay. So I'm doing, sorry, welcome to country and so forth.
Yes, that's correct.
Oh, sorry. I was thinking you were doing that. That's why I'm going a bit sort of hesitantly here. All right. So I'd like to start this session by acknowledging the traditional custodians of the land on which today's presenters are located. And I'd also like to pay respects to elders, both past and present, of the Kulin Nation, and extend that respect to Indigenous Australians present online. And so today I'm going to finally get going in sharing my screen so I can take you through this. Sorry about that. All right, I think we're back on track. And so today's session is we're beginning with we're having a panel discussion, and our wonderful panel members who are giving up their time to speak with us today is Associate Professor Ziyuan Wong, who is head of the Southern Melbourne Integrated Cancer Network. My colleague, Professor Lynn Gillan, who is the Academic Director at the Royal Children's Hospital and a professor at the Melbourne School of Population and Global Health at Melbourne University. Dr. Alex Clinch, who is the Deputy Director of Palliative Care at Peter MacCallum Cancer Centre, and Danielle Spence, who is head of, I'll just get the right term, sorry, head of strategy and support at the Cancer Council of Victoria. So welcome to the panel. Okay, so today we're covering via a couple of case examples, ethical challenges emerging in cancer care during COVID-19 and beyond. And through our discussion, we're going to highlight how a clinical ethics approach can help you to clarify and to critically think about ethical concerns and how to best respond to them. And before we begin, I'm sorry, I left out a couple of earlier slides because I was thinking that someone else was presenting those. I'm going to really quickly flick back to those. And there's just a bit of housekeeping, for those who are new to this cancer network. It is a joint initiative of the Victorian Comprehensive Cancer Council and also the Monash Partners Comprehensive Cancer Consortium. And you can follow this online network. You can join the online network, and you can also follow via these handles in social media. And the other, you probably are all familiar with this, but as this is a discussion, a case study discussion, we'd really love you to participate, and you can do it via these modes: question and answer, raise your virtual hand, or use the chat function, and we'll keep an eye on those. And if we don't get to see you or answer those questions, feel free to contact us via the online site or directly. Okay, so back to the start. So each day we get a report on the peaks the peak infection rate, and sadly the number of people who've died or who are in ICU. But our focus today is on the waves below those peaks and the ongoing impact of COVID. And I'm going to highlight those 4 waves. They include a second wave, which is the impact of resources, restrictions, loss of staff on urgent non-COVID conditions, including cancer. A third wave, which includes the impact of interrupted care on chronic conditions, and cancer care squarely fits in that area. And the fourth wave, which is the effect and the longer tail effect on mental illness and economic injury and burnout. And that's those 2 third and fourth waves is the focus of today's talk, and in particular, the ethical challenges encountered by clinicians as they continue to provide cancer care. And when I talk about, and when we talk today about continuity of cancer care, we're really looking at 3 dimensions: the relationship that you continue to build with your patients, the way you communicate with them, and how you can manage treatment over time with the various disruptions. And I'm going to use an Indigenous knowledge concept to join the notions of ethics and continuity of care. And I'd like you to think about this concept during the case discussions. So for the Pintupi people of Western Desert, Kanyeninpa is a term which means to hold. It's a deeply embedded value where authority is linked with nurturing. So it's used in multiple contexts when a person needs to be held by another, and when people are vulnerable and want to know and feel that those making decisions with and for them have authority and experience and do care. And I think patients with cancer may quickly come to depend on their cancer care clinicians in a qualitatively different and more intense way than a patient attending for a minor ailment to their GP. So in situations where their ongoing longevity depends on availability of cancer treatments, patients require their clinician to hold them. And I think these same values resonate with more standard principles that you'd be familiar with in health ethics: to benefit, to not harm, to respect the other person's needs, and to use the resources that you have fairly. But I think this idea of Kanyeninpa, or holding, tends to capture that idea of bringing in authority of evidence-based treatment and personalised, targeted and integrated cancer care, coupled with compassion and respect and giving people choice where you can. And another feature of this idea of holding is that the person doing the holding is calm, has some control even when there's not many options available to them, and is able to listen and reassure the other. And my colleague Brian McCoy, who applied this concept in his research with Aboriginal men, suggested that his insight about the power of holding came when he was sitting on the ground holding a child's marble as others were talking. And he suggests to hold something as you think and talk about this concept, as it's something that we can think about and describe, and that's what we'll do shortly, but it's also something that we feel as clinicians. And so what we're going to do now through the case studies is to I'm going to present each case as it might evolve in non-COVID times, and then add the layer of complexity and the challenges that the pandemic has added. And my colleague Lynn Gillam will take a clinical ethics approach to facilitate discussion and to ask questions that probe in detail how each situation affects your capacity to hold patients in cancer care. So our goal is to try to identify through this discussion what's ethically important and highlight a way to balance competing values in ethically complex situations. So we'll go to the case studies now. I'm going to start with this first one and just reinforcing that these case studies are an amalgam of different situations. They're not a real person that we're following. So our first case is 45-year-old female with newly diagnosed breast cancer. So in non-COVID times, sorry, flipped too early. In non-COVID times, she would present to breast screen, seen by a breast surgeon with locally advanced breast cancer. This would require an urgent medical oncology referral and possibly neoadjuvant chemotherapy to attempt breast conservation. She'd be seen by a medical oncologist and be offered probably standard of care or a clinical trial participation. And she opts for clinical trial and signs the consent the next day. The trial screening procedures can commence, and they include staging scans, biopsy for research purposes, and so on. Now, the impact of COVID means that she presented to breast screen in late June and couldn't attend earlier, even though she wanted to, because there was closures to the screening centres. The additional new COVID-19 safety measures mean that there was a pre-biopsy COVID-19 testing required, which required self-isolation, waiting for the results. That required rescheduling of staging scans. Because of shipping delays, she missed the shipping date of the tissue sample was missed for centralised testing, and that caused a further delay. So the patient becomes quite distressed by these delays, withdraws from the trial and opts for standard therapy. And another concern that she raises is that one of her friends underwent scalp cooling for her cancer treatment last year, and she was able to keep her hair and no one knew she was sick. But in her case and in her situation, scalp cooling wasn't offered because of COVID restrictions. So the questions, and I'm going to unshare my screen now and hand over to Lynn to start some questions about holding and COVID. And you're mute, Lynn.
Thank you. I thought I had Zoom taped, but obviously I haven't. So thanks, Claire, for that case. And what we're going to do now is start by asking the panellists, and I'll invite audience members through chat to respond to the idea, Claire's idea, that one way of understanding what's going on when you're providing care for patients, which is your ethical obligation, rather than calling it beneficence and think about doing good and respect for autonomy, respecting people's choices, is to frame it in terms of holding. And Claire's talked about holding as being both being nurturing, calm, reassuring, but also, I guess, holding authority, being an authority figure in some sense and giving some sense of control. So maybe, Zé, if I could start with you, does that encapsulate your experience? Does that ring true to you?
Yes, Lynn, absolutely. I think that when we see our patients who are obviously, distressed by a new diagnosis of cancer, we would like to reassure them in the first instance by staying calm ourselves. And it is a distressing situation for both the patient and their family. But at the same time, we want to use our medical knowledge and information, as well as, what are the clinical trials that the patient potentially may be eligible for, so that we offer a range of options to the patients. And then they could decide based on their personal preference, what they feel is appropriate for their situation to take up one of those options.
Yep. So, Zé, that's what you would do in normal times. In COVID times, as Claire's just presented, things don't turn out in quite that way. So how does it feel to be a clinician in the situation that Claire's just presented?
I suppose with COVID, it does throw a few challenges our way. I would recall during the first lockdown in March and April, a lot of the clinical trial activities were ceased for a period of time. And we know subsequently that fortunately the case numbers were not very high. We managed to actually reopen many of the trial activities. And during the second lockdown now, I would say in a lot of centers, the trial activities are continuing. So I think as clinicians, we would like to be able to offer our patients the options as long as it's safe and available, so that we could look at, what's the best choice for that particular patient sitting in front of us. And it's not going to be an all size fit all. I think it will have to be an individualized approach.
Yeah. So here's one question I'd like to pose to the panel and to the audience. Please jump in with your view. So the patient in this situation ended up deciding not to go ahead with the clinical trial. So is that a bad thing? Does that matter ethically? So she missed out on a trial, but of course the trial's not guaranteed to make her better off. So can I ask that really, it sounds like a bold question, does that matter? Danielle?
What we know at Cancer Council is that in these situations we'll hear from patients because they'll be ringing us for that additional information. And my question for the panel is there enough communication to help this person make the right decision? Is it because of fear and anxiety that things aren't happening quick enough that they're opting for standard care? And certainly in COVID, we know that there is a lot of waiting and there are a lot of additional processes for safety and other reasons that are being put in place. And that is impacting on people's treatment decision making capacity. And so I wonder whether there's a missing link here because we haven't communicated enough that it's okay to wait.
So is it okay to wait? Would it be okay for this patient to wait? Do the delays matter? Or could she have just kept going and said, yeah, I'll stay in the trial, I'll wait a few more days or a week or whatever?
Then I think it depends on the individual circumstances. Potentially it might still be okay depending on the window that we need to start treatment. So I guess it depends on, the exact clinical details of the patient. So I think it needs to be looked at on a case-by-case basis. And I would just add to Danielle's point that I think during COVID, there is an additional level of anxiety amongst patients, and I would say clinicians as well. So that sort of adds an additional layer of complexity that we have to navigate.
Yep. Alex.
Lynn, your question about is it bad that she missed out on the trial?
Yeah.
I don't think it's bad, but it's probably not as good. So she'll still get standard treatment, but what we know is that patients who are enrolled in clinical trials do better. And that's patients who get treatment or placebo or non-intervention arms.
Right. So there's something about being in the trial that's beneficial.
They have more sets of hands and eyes on them, I think. And so, we know patients do better in those settings.
Claire?
So does that mean, Alex or Z, that you would work harder to, how much persuasion do you try to use? Is it totally the patient's choice, or where's the authority line lie? Do you sort of suggest that they do better, or is it really their choice?
I think eventually it's the patient's choice, but I think our role as clinicians would be to give them enough information so that they can make an informed choice. Yeah. And, all the clinical trials which are approved will have, quite extensive and comprehensive informed consent. So we would normally go through with the patient, not on the first day, but, repeatedly and even over the phone outside of the formal clinic consult. So I think that additional information and opportunity for the patient to consider. And I would say some of my patients also go and see their GPs or contact their GPs in the interim just to get, the opinion from their GPs, whether the GPs thinks it's a good idea for them. But I think our role as cancer clinicians would be to provide the clinical information from that perspective of a potential benefit of being on the trial. As Alex has mentioned, that patients on clinical trials have been shown to actually do better, but it's not, that's statistics. It may not apply to this individual patient. Yeah. And certainly there's more attention to patients on clinical trials, certainly because of trial compliance.
So, Z, would you feel disappointed for this patient that she chose not to continue on with the clinical trial?
Lynn, it's a good question. I'm not sure disappointed is exactly how I feel. I would say that, if I were in the clinician shoes, I would feel that, well, we could have done more, but I think the circumstances were difficult, and we would respect the patient's decision to withdraw in her own best interest. And I think it's always what the patient is comfortable with. And I think trial participation is entirely voluntary, and it's not something that the patient should feel obligated just because their doctors mention it.
Yep. All right, audience, get ready on your chat. What I would like to know is whether you think it would be ethically appropriate for this patient's clinician to not force them to continue with the trial, but to strongly encourage them to do so, given the knowledge that we have that trial participation has benefits, and this is what she originally wanted. One way of reading what's going on is that she's panicked a bit because of the delay. Maybe holding her involves encouraging her to keep going down the pathway. So can you get on your chat and tell me, yes, you think the clinician should encourage or her to continue with the trial, or no, it's entirely up to her, don't encourage, just leave her to make her own choice. So
and perhaps maybe in COVID times, is there a change to that amount of encouragement?
Yeah. Sorry, thanks Claire for clarifying that. I mean in COVID times where what seems to have gone wrong is she made the choice and then it's become too hard because of COVID, but maybe what she really wanted was to continue if we could reassure her enough. So do you need to actually reassure and encourage a bit more? So Adrian reckons continue to encourage. Thanks, Adrian. So it sounds like Adrian would encourage anyway, but even more so in COVID times.
So Sophie's suggesting patient choice led by clinician
advocacy. Yeah, and I guess this is one of the things we're interested in here. So COVID's a difficult time. Does that mean clinicians need to, in some sense, step up their level of advocacy for patients, both in encouraging them to do things, but maybe also, Z, you might like to comment on this. Is there something that a clinician can do to try and hurry this procedure up? So it's been delayed because of COVID. Should the clinician step in and ring the lab and ring the theatre and try and push it along?
Lynn, I think that, the clinician, and I would say, the clinical trial team with the research coordinators would all actually strongly advocate for patients who are considering participation on clinical trials, COVID or non-COVID. But I guess there are certain circumstances which may be beyond what we can do, but we certainly will advocate to the best of our abilities.
So Linda's just made a really interesting point about need to ensure encouragement is backed by knowing how long the delays might take. And I guess different people cope with uncertainty in different ways. So maybe it depends a bit on that patient and their capacity to cope with that uncertainty. Danielle?
I'd also raise the question of what's the patient's expectations. If she's not starting a clinical trial, does she think she's starting chemotherapy the next day? Because it might mean that the day chemotherapy unit can't prioritise her for a week or 2 weeks. And are we giving her enough information?
Yeah, and if you look at Ashlyn's point there, scrolling back up, perhaps trial participation has additional COVID risks for her as well if she's got to come in more frequently than she would otherwise do if she's on standard of care. So it's actually, this is now a quite complicated decision to make.
And one more in the question and answer that you might not be able to see, Nick says, you can't really respond to whether or not you should advocate more or what you should do until we fully understand the patient's decision-making process, why she has chosen not to continue, which I think is where we're going to, isn't it? We need to, in influencing a patient, getting to know what they understand is part of that.
See.
Lynn, I'll just say that, truly what Claire said, that a lot depends on the rapport that the clinician has with the patient and potentially their family. Bearing in mind during COVID times when we see patients, generally they have limited opportunity for the family members to come in. I think most of the outpatient clinics allow just one family member to come with the patient, and sometimes the patient may come alone on their own.
So in this case, this patient made the call that it just got all too complicated. I'm wondering, clinicians, what you would think if she continued to hesitate, not sure what to do, got really anxious. Would you ever think it would be your position in terms of holding this patient to make the call for her? Look, it sounds like this is continuing in this trial is just getting too much for you. Why don't you just focus on going ahead with standard treatment? Or is that going too far? Is that stepping over the line from nurturing into too much authority? Who wants to go at that one? It's meant to be curly. I see, Danielle, now you've smiled, so you'll have to say something. But unmute yourself first.
You're muted, Danielle.
I think sometimes patients are wanting the authority, and you need to really decide, work with that patient around, is that going to be helpful to them? So some people will tell us at Cancer Council, I wish the doctors had just made the decision for me. They don't always understand what that means, but I think it does take time to explore that. And, you know, who's supporting this patient? Is there a breast care nurse? Is the research nurse there? Are we offering the same referral pathways in COVID that we would normally do? And I think that's something I'd like this group to be thinking about as well, because we know from the calls we're getting to Cancer Council that perhaps some of the supportive care screening and the other processes that we would normally see aren't possible for various different reasons. So are we supporting this person with the multidisciplinary team that we would usually turn to?
There's one question, there's a comment I just want to raise here in the question and answer from John. Are clinicians educated and equipped with necessary skills to deal with these types of scenarios? Which is an interesting question that sort of raises, is COVID having stretching the skills that you have? Do you feel like you need more and different types? I'd be interested, Alex and Z, about that. Do you feel with the challenges and the delays and the uncertainties that you need new skills?
I think that we are equipped to a certain extent with these skills. Anyone who's involved with clinical trials undergoes training to discuss these matters. And I think we also don't operate in isolation. So as a clinician, if we're stuck with a curly question, whether it's a clinical one or regarding a clinical trial, we've always got colleagues and others to actually, you know, discuss this with and come to a best solution.
Z?
Sorry, Claire, I'll just echo Alex's comments. And all new patients are discussed in the multidisciplinary team meetings. So there are other clinicians that we can tap shoulders on and ask, you know, for additional help. I think during COVID, it is very challenging times, and there's no textbook guide as to how we should be navigating this with our patients. So I think a lot really depends on the skills the clinician have with the team that's behind him or her. Yeah.
So Joanne has just made a really interesting comment in chat, which I would like to think about more. Due to physical restrictions on COVID-19, family and friend support may be limited, making personal decision-making harder, and that may create additional reliance on the healthcare team for support in decision-making. So Daniel, you were saying patients sometimes say, I wish the doctor had just decided for me or told me what to do. And I think Joanne's suggesting that feeling might be increased or magnified in COVID times. But I reckon that's a bit of a challenge for clinicians, isn't it? Because you don't want to decide for the patient. Is that right? You want them to decide? See?
Lynn, well, it's the patient's decision eventually, but I think our role really is to give them the information so that they can make a decision. We can make a recommendation, of course, and we would say that, you know, in the patient's individual circumstances, we recommend A versus B, but ultimately it's the patient's choice.
Yep. So in the end, if this patient C said, should I continue on this trial, what would you say?
I think depending on the circumstances as it is, we don't have all of the details. If the clinical risk of delaying her treatment is permissible for her outcome not to be affected eventually, then we would probably encourage the patient to stay on the trial with the reassurance. But if otherwise that it may be detrimental for the patient to wait, you know, for additional number of weeks, then I think we would advise the patient otherwise.
Alex, do you have a brief comment there? Oh, Claire's about to do time things to me, are you, Claire?
I am going to, yeah. So final comment.
I think with this sort of decision, it helps to know your patient. And so to be able to understand what their comfort level is with uncertainty. And I think also being stuck with a difficult decision, actually making no decision is sometimes worse than actually making some sort of decision, and sort of believing between you and the patient that at the time you're making the best decision you can.
Yeah. We'll come back to this with our second case, I think. Now, what we didn't discuss here, Claire, have we really run out of time?
Well, we have, but you can have...
Can I have 1 minute?
You can.
What we haven't we haven't talked about the scalp cooling. So this patient missed out on scalp cooling, not by her own choice. I don't know whether she was told that she would normally get it and it isn't available now, or whether that was not just mentioned, but that seems to be in a different category, isn't it? Presumably, the treating clinician would have had no control over that. It just happened. Would you have told her that she was going to miss out on something she would ordinarily get?
No, I think most clinicians operate under different circumstances during COVID, and some centers are able to continue to offer that, while other centers do not, due to, you know, circumstances within the health service.
Yep.
So if the health service that this patient attends is not able to offer, then clearly we won't be mentioning to the patient.
You wouldn't mention it to the patient?
Well, you know, it's hard. It's hard to.
Can we go to the audience?
Hard to say you want to mention to the patient something that she can't.
Danielle wants to speak.
Yeah. I think the challenge. Do you ring around and see who is offering scalp cooling and let the patient know that there might be an alternative, health service that could support that if she felt really strongly about that. So how strongly does she feel? And I think, advocacy organisations like VCCN would probably want to see that this person was able to get that referral to a service. It's COVID time, so that's difficult.
Because the other side of that is that fair, because then those services that are still offering scalp cooling then start to get overloaded with patients, don't they? We can't pursue this any further, but there's chat and Q&A there for you to send in your comments. I'd be really interested to hear, would you tell her, would you try and get her in somewhere else, possibly at the expense of another patient, on the basis that she's your patient and she's yours to hold, not somebody else's? So keep those questions in mind. Any answers or responses would be great. And we'll go on to the second case.
Yeah, the second case sort of delves a bit more into those sorts of things as well, I think, but that's not the second case.
No, it's the end of the first one. Here we go.
This is a case of Mr. AB, who is 78-year-old with metastatic pancreatic cancer, living alone in out of Melbourne. A Greek migrant who speaks English but is a little bit limited, lives on his own, but has a supportive daughter living in the inner city. He's pretty fit for his age, getting around by himself. And he presented with 2 months of progressive abdominal pain to his GP. Clinical workup with imaging and biopsy confirms pancreatic adenocarcinoma with some metastases. So in non-COVID times, there'd be a discussion for him regarding treatment options, and they would probably include systemic chemotherapy with a palliative intent and some symptom control. But the priority would be quality of life. So the discussion here, again, the overarching questions is which aspects of continuity of care are more challenging in this type of situation. And these questions about how he's going to manage his treatment and the side effects of the cancer living alone, risks of immunosuppression if he goes on to chemotherapy, whether he should stay with his daughter, and his daughter's situation is that she works in a supermarket, she has young children at home, and actually at the moment she lives in a hotspot. and whether or not he should come into hospital, knowing that his daughter won't be able to visit. So that's
Alex, can we get a bit of help here? So this patient has opted for a palliative pathway, but having done that, what are the options open to him? There's palliative care at home. Are there other choices? Are there choices to be made within palliative care at home?
So in this current climate, the supports available in the community have actually been more limited. So nursing visits into the home have been scaled back, and there's more telephone and telehealth occurring, which is balancing up staff risk versus patient care.
Yep.
They still do go into the home when needed for clinical assessment or care, particularly at the end of life. But the picture we're seeing in the community is different these days.
Yeah. So for this gentleman, if he's living home alone, in pre-COVID times, would someone have gone into him every day or every few days?
No,
and how is it different now?
I mean, someone that's, relatively stable, not too symptomatic, might only get a visit every 2 or 3 weeks even, but have, the availability of on-call sort of phone contact if needed.
Yep. So as a palliative care physician, do you feel that he would be disadvantaged now relative to how he might have been if he'd got this cancer last year?
I think so. I mean, I think having been involved with community teams and going into patients' home, it's invaluable. Being able to see them in their environment and provide the care where they live is really important. For us as clinicians to even understand our patients better, but particularly for our patients, it's a really important part of their care. So their care at home does look different now.
So how does that make you feel if you were this gentleman's treating doctor? How do you feel about that?
I feel like we can still get by with telehealth, but it's not as good. It's not the same.
Would you say that to him?
I think, well, it's interesting with patients that I have been seeing with telehealth, a lot of them actually do prefer it in some ways. They prefer not having to come into the hospital for outpatient clinics. They're scared. And even some of the patients don't mind so much that there aren't, strangers coming into the home potentially spreading COVID. So,
yep. So Alex, do you reckon it feels more worse? Am I allowed to say more worse? Does it feel more worse to you than to the patients? Maybe you've got a better idea of what they're missing out on.
Well, I wonder, is it my feeling that they're not getting what we felt was best for them? Where in fact in this climate, some of the patients actually would prefer not to have as much contact. I don't know, it's a very individual thing.
Now, he could go and live with his daughter and that would give him more support. If he were to ask your advice about that, what would your advice be, Alex? And audience, please, in chat or Q&A, what would your advice be if he asked for advice? Should I go and live with my daughter? Would that be a good idea?
Or if he wants to go and live with his daughter, even because he's feeling
a bit lonely, feeling the need of support.
Yeah.
Would you encourage him, dissuade him? Would you, as we've been talking about before, say, well, it's entirely up to you?
Well, I would explore the reasons for why he wanted to do that. So if it was that he was feeling distressed and anxious at living alone, then the comfort of living with a carer would, I think, help him. But it's not without risk. I don't know how we can easily measure and balance that risk.
Would you point out the risks to him?
Yeah, you might. And so there may be ways to mitigate that risk. So reinforcing things like physical distancing and hand hygiene and all the other things that we're doing.
Yep, but you laughed a little bit there. Why did you laugh?
I don't know. It's become so ubiquitous these days. it's all we do at work. And I don't even know in the community how many people observe that within their own homes.
Yeah, that's what I was wondering. So there's the daughter, she's working, she's got kids, I think. So would that really happen? For all that you might advise it.
I think people who work in supermarkets themselves are probably pretty afraid and pretty careful with things too. So.
Yep. So Sarah says, what about hugging the grandkids? Would you tell him not to?
I suppose I would talk about the risks that might pose, balancing that with the very important and human thing of having a hug.
Yeah. So this is a really different experience of palliative care with cancer than it would have been a year ago, isn't it? When you're talking about these sorts of things.
I think it is, and that certainly when we consider venue of care and whether someone stays at home or is looked after as an inpatient, that's the big change that I'm feeling at the moment.
So the visitor sort of restriction problem is really also at home, isn't it? That lack of, I mean, it's not to the same extent, but there are real restrictions in how many people and how close you can get.
So he's safer at home, but arguably he might have a better but less safe experience living with his daughter.
Yeah, potentially.
Danielle, do you have a comment there?
No, Danielle might not have heard. Can I just read Heidi's comment?
Yes, please.
Sorry, I'm having a little bit of trouble. Sorry, did you ask a question of me there? I just dropped out a little bit.
We might go to the next comment and then come back to you, Danielle.
Yeah, Heidi's suggesting if he's being palliated, would the weighing up be the benefits of enriching his life with personal contact in his palliative stage versus catching COVID and maybe dying a little sooner? It's an interesting comment, but there's more to those. There's another thing to weigh in, and that's the safety of the family, I suppose, too, isn't there? The safety of his...
Let's go for the first bit first.
Yeah.
So I think Heidi might be suggesting, tell me what you think, Alex, that since he's on a palliative pathway, that means we're accepting that he's going to die. If he gets a COVID infection, he might die sooner. How much does that matter in comparison to having the opportunity to have his family around him?
It's an incredibly complex scenario. So I think we're weighing up benefit and burdens of, human physical contact in this sort of scenario. And the other complicated issue we're seeing happening in real life is that when people get COVID, often there are multiple family members affected. And the elderly and the frail have much higher mortality, and we're seeing even quite complicated bereavement issues with an elderly relative who's caught it from a young, well relative and has died, and the repercussions and fallout from that.
So in fact, this could have a significant impact on his daughter, who might well get infected at work at the supermarket, bring it home. She doesn't get very sick, but her father dies.
Yeah, so we're seeing sort of a different landscape of sort of guilt and bereavement risk in these cases. But then the alternative is that an elderly, frail person at the end of their life spends that time alone. I don't know that we can sort of easily measure and balance these things. Yeah.
So in fact, that was going to be the final question I wanted to pose to you and the audience. If he actually wanted to go and live with his daughter, would you actively dissuade him on the basis of risk?
I don't think I would. I think we would discuss the risk, but I think ultimately it's for him to decide.
And if you wanted him to come in for an inpatient admission to get better symptom management, but he didn't want to because he didn't want to be in a situation where he couldn't have visitors, again, would you encourage him to come in and cope with the lack of visitors, or would you essentially be leaving that to his call? you know you can get better symptom management if he comes in. He wants to stay with his family in the community.
Yeah. Or even we're seeing scenarios where patients we know will be better off in an inpatient setting, but they're afraid to come in because they're worried that they'll catch COVID in hospital.
Yep.
But this decision, it's not so black and white, because we can actually, particularly for palliative care patients, apply for exemptions for visitation.
Right. So there might be some room to manoeuvre.
There's some wriggle room in it.
Yep.
And so I think it's a balance. And again, it's for patients to understand what their options are and to make that decision.
And there's a few comments coming in to say the importance of sort of involving the family and other health professionals in this decision.
Yeah, I'm thinking about that comment of involving the daughter, since she would have an important role in this. Danielle, did you just wave your hand?
Yeah, look, I think, this person is going to become more unwell. And so what are we going to do when he has to come into hospital because he needs, urgent symptom relief? And are we preparing him for that? And I'd like to comment too on the Alexandra's point about, we can have, compassionate access for visitors, for people in palliative care. What we know and we're hearing really loudly is that that's not always as easy, especially for people who aren't as health literate. This person doesn't speak English as well.
Yeah.
It's not easy to advocate that you need people with you. Grandchildren, people under 18 are not allowed. There's blanket rules around that. And, they might be important to him in his life. So I think I really want people to understand that it's not always as easy for patients to be advocating for themselves, and they need help and they don't always know where to get that from.
Yeah. So maybe just a final comment here. I'm aware of the time, Cynthia, but that question of advocacy is coming up again. What does the clinician owe to the patient in terms of maybe extra advocacy at this time, precisely for the sort of reason Danielle's talking about? Claire, I reckon I better hand back to you to tidy everything up.
Yeah, thank you, Lynn. So we've just got the final couple of slides so we don't run out of time, and trying to sort of draw the ideas together. I think I've got 3 summing up slides here. Some of the responses that I think were apparent when discussing these cases, and we didn't even get on to I think a really big topic, which is managing visitor restrictions with patients. But I think what's coming out is that this idea of moral distress, and that's a term that's used quite a bit, but it is a feeling that you have, if you are required as a clinician to do something that you think is wrong, is ethically wrong. And it usually occurs when you're being required to do it, or you have to do this thing, which is a decision made by somebody else. And I think the increasing and changing regulations on how you can practice at the moment might put you into this space where you think that what's occurring for a patient is actually wrong, but you can't do anything about it. Another sort of feeling that came out of that discussion was perhaps moral anxiety, and that's more just being worried or afraid about a decision that you might have to make in the future. And one of the key features of COVID is a state of uncertainty. How is it going to affect things in the future? Moral tension is something that is well represented too in these sort of cases, where there's a number of options available, but it's pretty unclear about which option to pursue. I think that's a feature sometimes in some areas of cancer care, but perhaps it's exacerbated even more with COVID. But one of the things that it might be when you have a discussion like we've just had is that you get to this idea that perhaps what you're feeling is not so much distress because you're doing the wrong thing, but more moral regret, that you are aware that some values aren't being fulfilled. you know, you're feeling bad because something has to be sacrificed here. This patient can't get the same treatment that they might ordinarily have got. But it's not that the wrong thing is being done, it's because of the circumstances. So that's a message that has come out as well. And so a take-home message from today's webinar is that there is great value in having discussions like this with colleagues, just talking about your experiences, what you think is uncertain or what feels wrong to you. And a clinical ethics approach, what we've done today is just try to, through questions and discussion, identify what is ethically important in situations and how you might balance competing values. What's your perspective about those values and how should you respond? So it sort of starts to give you this language and ways of understanding whether you are feeling distressed, anxious about something in the future, or whether you're just feeling sad because it is pretty tragic what's happening to some people. So final comment I'll ask the clinicians is how are you practically managing this, holding? What sort of authority are you using? Is it different to usual? And how are you nurturing others? And are you able to stay calm so that you can reassure, listen, and have some control? So Ziwan, maybe you can answer that one or give us some ideas first.
Yeah, thanks, Claire. I guess, you know, each one of us manage it in a different way. Some of the strategies that, you know, myself and others have used is to try and get updated information, you know, as timely as we can. But there's a fine balance there to having too much information and get overburdened. And so you almost need to sometimes tune out, you know, from time to time if you are feeling overly burdened. And I think having that family support, you know, family members, and as illustrated in the second case, was really, really important, I think. And finally, I think with the colleagues that you work with, you know, you sort of feel a sense that you're in this together, and being involved in networks like this, like the VCCN, and being involved in different working groups, gives you a sense that you can contribute and do something about your situation. We can't change COVID until we get a vaccine, perhaps, but you know, if you're feeling that you're actively doing something about the situation, that helps you to feel better and more positive. And I think, and the others, you know, I know some health services, myself included, we've actually started a social Zoom on a weekly basis with some of our colleagues to, you know, chill out at the end of a weekday, towards the end of the week, to just, you know, share different experience. And, you know, that is a way to recharge for some of us. And I think finally, to just take a day at a time and not try and think what's going to happen in 3 months or 6 months, because no one really knows. And being able to break that down so it's less overwhelming. These are some of the strategies I personally do adopt, but, you know, I'm sure there are others out there.
Thanks, Ziwan. Alex, do you have any other thoughts about that? How are you doing that Carnino? Oh, now I'm not going to be able to say it. I've said it the correct way all the way through.
How am I holding?
Yeah.
I feel like with our patients, we're needing to hold them a bit more. I think we're seeing heightened levels of distress and anxiety. And similarly, we're needing to hold ourselves and each other, our colleagues. So I think the extraordinary nature of this situation is that it is global, and the anxieties and stresses and isolation our patients have, our healthcare workers have too. And that collegial support and holding each other, I think, is a really important part of it.
Can I just leave people with a question on that in the remaining 2 minutes? So if clinicians are feeling a bit stressed and anxious themselves, and patients are feeling stressed and anxious, I'm wondering to what extent it's the job of clinicians to hide their own stress and anxiety, to be confident, calm and reassured for their patients, or whether some sharing of anxiety and uncertainty and finding life hard is an okay or even a good thing to do.
Do we add ourselves as the wounded healer? Are you asking?
Yeah, I sort of. You haven't got the same condition, but we've all got COVID anxiety.
Yeah. I mean, with things like visitation, we talk very openly about how difficult it is. I think to hold our patients to some extent, they need to know that we can do that though. And so it's not our role to, I think, divulge our deepest and darkest anxieties and fears. I think that sort of thing is actually better done with our colleagues.
Right.
With our patients, we still need to assure them that we're going to be there to help hold them.
Yep. Thanks for that response, Alex. Claire, hand over to you to finish up.
Okay, thank you, Lynn. And I'd like to thank all of the panelists for this conversation. I hope that it's stimulated some more and more questions and reflection from the audience. So we'd be very happy to speak with you offline and through the VCCN Slack workspace, if you're a user of that, which hopefully you are. And to finish off now, I just want to highlight that the next event is on Friday the 11th of September, and the topic is clinical trials during a healthcare crisis. So once again, thanks very much to Danielle, Ziwan, Alex and Lynn, and a great discussion, and thanks for the opportunity.
Thanks, Claire.
Okay,
Thank
thank you.
Bye.